What do you do when the blood pressure reads a low number you don't like? Most providers hit the button again, maybe adjust the cuff. But what if it's real? How do you act? What do you reach for? Welcome to the Loud and Clear podcast. For those of you new to the show, I'm Ross Orpit, and with my co-host Will Berry, we bring you content designed to teach one step past what you learned in paramedic school. But in an age where content and education is now endless, we need to most understand what our guiding principles are. So on every episode, we connect our discussions back to a set of principles that help you understand what actually matters in the moment to the patient in front of you. Today, we're talking vasopressors, blood pressure management, and why the medications we used a decade ago would get you sideways looks in 2025. This episode was recorded on site at the FASTCAN conference in Calgary this year, right after our guest delivered an awesome lecture on this very topic. Thanks so much to Master Your Medics for inviting us up to perform these lecture debriefs, and to FlightBridge Ed for partnering with them to bring this great conference to life in Canada. This is just a debrief of the full lecture. So if you guys enjoy it, definitely think about checking out the conference in person next year. It was great. Our guest is James Boomhower, a critical care transport flight specialist with Boston MedFlight and founder of Stay Fit for Duty. James lives in the space between the emergency department and the ICU, where seconds matter, protocols get tested, and sometimes multiple pressors still aren't enough. In this conversation, we'll break down when to start treatment, why norepinephrine replaced dopamine as the go-to vasopressor, and what to do when your patient is on 3 drips and the pressure still won't come up. So whether you're a seasoned flight medic or a new paramedic trying to make sense of your protocols, there's something in here for you.
You on 8. You on 8. Okay, you're clear. Stand by for your base.
Welcome to the Loud and Clear podcast. Thanks for joining us after your lecture here at FASTCAN. First question I have for you, tell me about the Krebs cycle.
No. Next question.
Okay. All right. So your talk today was about vasopressors. And first and foremost, you opened up a question of what do we do when we don't get a blood pressure we like?
Recycle it, right? So we push the button again. We said something must be wrong with the machine, not the patient, right?
Let's try that again.
Yeah, exactly.
So what should we do then? I guess first and foremost, maybe when is a non-invasive blood pressure inaccurate?
Yeah, I mean, I think there's a lot of truth to it, right? First and foremost, make sure it's on correctly, make sure it's sized right. I talked for a couple minutes about how to size it, how to make sure it fits the patient. And what we didn't talk about is kind of how to mitigate that if patients don't fit those standard blood pressure cuff sizes and what are some auxiliary sizes we can do. But first thing you have to do is make sure you're getting as accurate a non-invasive blood pressure as possible. And then from there, you have to believe it, right? Once you've done all the troubleshooting, unless you have glaring evidence to the contrary or an LVAD or something that could really manipulate non-invasive blood pressures, you have to believe it and you have to start to work to mitigate that.
Yeah. So we believe it.
Yeah.
When do we start to do something about it?
So my school of thought is after your second recycle, right, you should be mixing pressors, right? And the pressors that you choose are kind of dictated by your protocols. And in a perfect world, as we talked about in my presentation, can we look at why the patient is sick, why the patient is hypotensive, and can we use that and acknowledge their pre-existing medical history to say, am I choosing the right agent for why their heart might be failing?
Let's break that down further. So we believe the blood pressure.
Totally.
We need to do something about it.
Yep.
Where do we start?
So I think Levoped's a perfectly fine choice. I really do. I think for 99% of your patients, especially when we look at our protocols in adult patients with hypotension, I think it's a perfectly appropriate first line agent. I know we talked briefly about fluid and recognizing when it's valuable and when it's not. So I guess my answer was kind of predicated by the fact you've already given a fluid bolus appropriate to the patient. I think Levo is a very appropriate first line choice.
And this has changed in our careers, right? You mentioned that up there. Like I'm right there with you. I grew up in an age or started in an age where dopamine was king. And now dopamine is dead and norepinephrine is king.
Yeah. Yep. And when norepinephrine used to be, Levoped meant leave him dead, right? He's really kind of pushed back against.
Yeah. And do you know why that's come about?
My only assumption is the modernization and availability of evidence-based data and how we're running less off dogma and more off of evidence.
Yeah, that's exactly it. I think I actually did a talk on this during my residency about it. And as we started to study it, we found that medications like dopamine, which had more chronotropy, tended to cause more arrhythmias. And when people had more arrhythmias, their outcomes were worse. And we found again and again that norepinephrine caused less arrhythmias and tend to have better mortality at the end of the day. Why is it important to Goldilocks this and get this blood pressure right?
I think unfortunately in transport, we still kind of believe that we're allowed to be a little lax, right? The blood pressure doesn't have to be perfect. We can ignore a handful of junky blood pressures, right? Or we can throw our hands up and say there was nothing we can do. And I don't think that's the right way to approach patient care as a whole, but I certainly don't think as a professional advocate of emergency medical services and critical care transport that we should allow that to happen, right? We're all very quick to poo-poo, especially in the critical care arena, other physicians that do that, right? We walk into someone grossly hemodynamically unstable and a doc with his hands in his lab coat. We react to that, right? We're really put off by that. But yet we have providers who will a couple of way off blood pressures when really that was the cue that you should have started to work.
When you're thinking about these vasoactives, how do you organize these in your head?
I think protocol plays a huge role, right? It's magical to say you have the entire stack, at your disposal. So I think your protocol plays a big role. I think the availability of what you have plays a big role. And truly, what's going to be the fastest to put up, right? What can I start with? And again, for me, that's Levophed, right? Easy to mix, easy to set, really standardized dosing throughout the continuum, right? I can put that up in a second. When I look at medications for me in my agency that might not be immediately at hand, maybe I need to go to the aircraft to get that medication, or I don't have access to that medication. I need the pharmacy to grab it. I personally, for my first one, maybe two pressors, think very logistically, right? What does my protocol say? And then what do I have closest at hand?
Yeah. And as we start to affect that blood pressure, is it better to just get it up as quick as you can? Yeah. Or is it better to be slow, controlled, get it up? Or where's the Goldilocks in that approach?
Sure. I think that depends on where the blood pressure is, right? If you're kind of hovering with someone who's below goal, right? And maybe if you talk to a different physician or had a different set of protocols, you might not play with it. Or we have to do this, or we're going to code. I think that really drives how much I'm willing to increase the blood pressure. But in a perfect world, I'd like to see a slow and steady increase rather than 60 over dead to 120 over 80, right? That's a lot of stress for our patient to undergo in a short period of time.
What do you do when your pressors just aren't working?
I have a handful of options, right? I spoke at the end of my talk about zooming out. Have we missed something? Is the tube in the wrong place? Is there a pneumo? Is there a cardiac tamponade, right? Is someone bleeding all over the place that we just haven't recognized? Pharmacologically, I'm a big fan of steroids. I really am. I know that's not the most popular opinion in the world, but man, to get you out of the metaphorical suck, I think they can be really helpful, especially in patients that have been sick for a long time. And then if you have it or have access to it, I think methylene blue is a great additional adjunct, not the med, but an adjunct. Really, again, as we talk about the Krebs cycle, right? And when we talk about how these medications work, the way that I conceptualize methylene blue makes the system work better, right? It kind of makes all of our pressors a little bit more effective by increasing that vasoconstriction or ability to vasoconstrict rather than be a medication that can do the job, if that makes sense.
Yeah, absolutely. I think one other thing I would throw out there is when somebody is profoundly acidotic, the way that works is their blood vessels just cannot squeeze because of that acidosis. And so another thing I would add in is thinking about sodium bicarb, maybe.
Totally.
Patient who's on multiple pressors, so how things working.
Absolutely. Yeah. And what kind of on that front, and again, there's a 20-minute version of this talk, and there's an hour version of this talk, right? But, are we ventilating in a way that is helpful, right? Have we just mimicked vent settings without thinking, how can we correct this acidemia to either make the pressors work better or we see the other problem?
Yeah, absolutely.
But I love bicarb.
Yeah. What do you feel was the biggest, as you prepared for this talk, the biggest take home in your own learning when you were preparing for this?
I was not ashamed. I was surprised at how much I had to relearn about vasopressin, right? Talking about V1, V2 and how that all works. And you really being like, oh yeah, that is kind of how that works, right? Because for the longest time, it was my second agent and it was set it and forget it. For a minute and a half, we had high dose vaso for some GI vasoconstriction, which in my agency in New England, we don't operate off of that anymore. Way more harm than good in our medical director's eyes. But I thought it was great to kind of go back to medic school and be like, but how do these drugs work? How do they happen? And then how can you distill that and entertain not only a fellow critical care professional, but the new nurses and new paramedics that are here? How do you thread that needle of giving them both something to walk away with?
Yeah. Don't be ashamed of that. That's growth, man.
Yeah, man.
Yeah. Striving for a beginner's mindset is the sign of a true master.
Totally. I appreciate that.
James, thanks so much for sitting down with me. It's always a pleasure to hear you talk. So much energy, so much fun.
Likewise, man. Thank you for having me. I appreciate it.
Thanks.
So there you have it. A masterclass in vasopressor management from someone who lives it every day at 10,000 feet. Let's recap the key takeaways from our conversation with James. First, believe your blood pressure reading. After you've troubleshooted the cuff size and placement, trust what the monitor is telling you. By your second recycle, you should be starting pressors. Second, norepinephrine is your first-line agent for a good reason. The evidence is clear. It causes fewer arrhythmias and better mortality outcomes than dopamine. But your agency may not carry norepinephrine for many logistical reasons, including storage and alternative uses for other emergencies that epinephrine can provide. So epinephrine may be what you have access to, and that's okay, because our third principle is to think logistically in the moment. Your first pressor choice should balance what your protocol allows, what you have immediately available, and what you can start the fastest. Fourth, when pressors aren't working, zoom out. Is the tube misplaced? Is there a pneumothorax, cardiac tamponade, unrecognized bleeding, a severe acidosis? Don't just add another drip without looking for an underlying problem. And fifth, consider your adjuncts. Steroids, methylene blue, and sodium bicarb all have a place when you're in deep. And don't forget, are you ventilating in a way that's correcting the acidosis? Or are your vent settings working against you? But here's what I want you to remember above all else: the guiding principles that matter most. 1, hypotension kills through hypoperfusion. Every minute with inadequate blood pressure means organs aren't getting what they need. 2, your patient can't wait for perfect. Start with what you have and what you know, then refine as you go. 3, slow and steady wins the race. Going from 60 over nothing to 120 over 80 in 2 minutes may create more problems than it solves. And finally, 4, never accept hands in the lab coat. This holds true whether you're a physician, a flight medic, or a new paramedic. When the blood pressure is tanking, that's your clue to work, not to shrug, not to wait, to work. James said something that stuck with me. He had to relearn vasopressin pharmacology to teach this lecture. Striving for a beginner's mindset is the sign of a true master. That's not a weakness, that's growth. That's what keeps us sharp. If you haven't heard, we've started a course for paramedics who strive for just that, to strive for a beginner's mindset and become masters in the craft of paramedicine. We're opening up enrollment again in November. So if you're interested in joining an awesome group of like-minded paramedics striving to be the best they can be and get personalized training to help you take your skills to the next level, send me an email at ross@emspodcast.com to learn more. Whatever you do, keep learning, keep questioning, and when the monitor shows a pressure you don't like, believe it and get to work. Thanks for listening to the Loud and Clear podcast. If you found this valuable, share it with someone on your crew who needs to hear it. Follow us on Instagram or YouTube at EMS Loud and Clear, and check out our website for supplemental blog posts at emsloudandclear.com. Until next time, stay safe out there.